Hi friends, good day. Today we will discuss about ductus arteriosus dependent cardiac lesions. Ductus arteriosus dependent cardiac lesions. Usually in the fetal circulation, the ductus arteriosus will be patent. This helps in the mixing of deoxygenated and oxygenated blood in the fetal circulation, but immediately after fetal circulation this ductus arteriosus closes. Okay, but if in some babies there will be obstruction to the pulmonary blood flow, pulmonary outflow tract obstruction or systemic blood flow tract obstruction. So in obstruction to the pulmonary blood flow, the blood will not reach the lungs for the oxygenation, whereas in obstruction to the systemic blood flow, the blood will not reach the systemic circulation to supply the all organs of the body. So due to this obstruction, there is impairment of the circulation either to the lungs or to the systemic organs. To avoid this, the ductus arteriosus should be patent, because it helps in the mixing of oxygenated blood from the pulmonary circulation with and deoxygenated blood. So if there is obstruction of the pulmonary blood flow or systemic blood flow, the ductus arteriosus should be patent, compulsory. So these lesions are dependent on these cardiac lesions in which there is obstruction to pulmonary blood flow or obstruction to the systemic blood flow. They are dependent on the ductus arteriosus. Okay, so ductus arteriosus should be patent even after birth. Usually it will be patent in the fetal circulation, but in these conditions where there is obstruction to pulmonary blood flow or obstruction to systemic blood flow, in these cardiac lesions where this obstruction is there, the ductus arteriosus should be patent even after the birth. Okay, these cardiac lesions are two types, I already told. Either there will be obstruction to the pulmonary blood flow or obstruction to the systemic blood flow. So if there is obstruction to the pulmonary blood flow, pulmonary outflow tract obstruction, okay, either right ventricular outflow tract obstruction, means there will be obstruction in the pulmonary arteries which carries the deoxygenated blood from the right ventricle to the lungs. Okay, the blood flow from the right ventricles, deoxygenated blood flow from the right ventricles to the lungs is impaired in this obstruction to the pulmonary blood flow. Due to this, there will be, if the blood does not go to the lungs, it cannot be oxygenated. Okay, you understood? That's why there will be many clinical features. So first we will discuss about obstruction to the pulmonary blood flow. How it will present? It will present with cyanosis, low saturations. Okay, despite of oxygen supply, there will be low saturations in the baby. If you supply with oxygen also, the saturations will not improve. Or if you connect to the ventilator, means if you do positive pressure ventilation with ambu bag, or if you intubate and connect to the ventilator, then also this cyanosis and low saturations will not improve if there is obstruction to the pulmonary blood flow. And there will be respiratory distress because because there is cyanosis and low SpO2, and there will be respiratory distress, and also poor perfusion, because whenever there is respiratory acidosis, because there is the oxygenated blood is not supplying to the organs, there will be acidosis. Okay, there will be due to hypoxia and acidosis. These acidosis will impair the cardiac function also. Cardiac function will be impaired due to this acidosis. This will lead to poor perfusion. Because cardiac function is impaired because of acidosis, poor perfusion will be there. So there will be cyanosis, there will be less SpO2 despite of oxygen or ventilator support. Respiratory distress will be there, poor perfusion will be there. Okay, so mainly in the pulmonary blood flow obstruction you will see the cyanosis. So if you see the cyanosis which is not improving, or low SpO2 which is not improving even after oxygen support or ventilator support, then you should suspect the duct dependent pulmonary blood flow, pulmonary lesion. Okay, obstruction to the pulmonary blood flow. Okay, so presents 12 hours to 48 hours after birth, because PDA will completely close in 12 to 48 hours after birth. So until the PDA is open, the deoxygenated and oxygenated blood will mix, and it will help in the supply of the blood to either lungs or either the systemic circulation. But when the PDA is starting closing from completely closure of PDA occurs from 12 to 48 hours, at that time these lesions, the clinical features of these lesions will present. When if the severity is more, if the obstruction is more, then the clinical features may present earlier, immediately, either 4 to 8 hours of birth or 12 hours of birth. If the obstruction is little, if it's not so severe, then it may present after 48 hours. Okay, so it depends on the level of obstruction, how soon it will appear. Okay, depending on the severity of the lesion, when the duct starts to close. So when the duct starts to close, depending on the severity of the lesion, these clinical features will be present. Can be differentiated from respiratory lesions like pneumonia, hyaline membrane disease, congenital pneumonia. So you should differentiate these lesions, because in severe hyaline membrane disease, severe congenital pneumonia also, there will be cyanosis, low saturation. So how to differentiate from the respiratory lesions like hyaline membrane disease and congenital pneumonia is by hyperoxia test. So if you give 100% FiO2 for 10 to 15 minutes, okay, if you give 100% FiO2 with the nasal prongs or mask for 10 to 15 minutes, then the saturation should improve. If the saturations are not improving, it's not the respiratory lesion. At least some amount of saturation should improve if it is a pulmonary lesion. Okay, if there is a pulmonary parenchymal lesion like HMD or hyaline membrane disease or congenital pneumonia, if you supply with 100% FiO2 for 10 to 15 minutes, at least there should be little improvement in saturations, or if you perform ABG, then there will be improvement in the PaO2. Okay, oxygen saturation, pulmonary arterial oxygen saturation. Okay, in ABG, if it is not improving, then it's not a pulmonary parenchymal lesion. It can be either cyanotic heart disease like pulmonary blood obstruction to pulmonary blood flow, or sometimes the PPHN also can be presented like this, persistent pulmonary hypertension of newborn. Okay, next comes how to differentiate from. So you ruled out the respiratory parenchymal lesions. Now you should differentiate from respiratory pulmonary arterial. Pulmonary parenchymal lesions you ruled out with the hyperoxia test, which is giving 100% FiO2 for 10 to 15 minutes. Then also saturations of PaO2 if does not increase in ABG, you can rule out the pulmonary parenchymal lesions. Now we should differentiate between pulmonary arterial hypertension, pulmonary arterial lesions like persistent pulmonary hypertension of the newborn. From this obstruction, from this cyanotic heart disease, that is obstruction to pulmonary blood flow, you should differentiate. How you will differentiate is by when hyperventilation test, hyperventilation hyperoxia test. You should give 100% FiO2 and ventilate with 100 to 150 breaths per minute, either with ambu bag or with ventilator. You should ventilate with 100 to 150 breaths per minute with 100% FiO2. Okay, for 10 minutes. If there is increase in saturations or increase in PaO2 in the ABG, then it is PPHN, persistent pulmonary hypertension of newborn. With if the saturation increase with hyperventilation hyperoxia test by giving 100% FiO2 with 100 to 150 breaths per minute for 10 minutes, then if the oxygen saturations improve, then it is pulmonary persistent hypertension of newborn. If there is no change, then it is cyanotic heart disease where there is obstruction to pulmonary blood flow. Okay, examples of this right ventricular pulmonary outflow tract obstruction are severe pulmonary Examples of these lesions: severe pulmonary stenosis, pulmonary atresia. So you know, if in these lesions the pulmonary artery outflow is obstructed. The blood cannot go to the lungs for oxygenation. Deoxygenated blood cannot go to the lungs. Examples are pulmonary stenosis, severe pulmonary stenosis, pulmonary atresia, means the pulmonary wall will be completely closed. Epstein's anomaly. Okay, Epstein's anomaly is nothing but the atrialization of the right ventricle, right atrium, atrialization of the right ventricle. So here the tricuspid wall will be approaching downward. It will be very loose. It will close the pulmonary wall. It will completely collapse into the right ventricle, and it will collapse the pulmonary wall, and it will obstruct the right ventricular outflow tract. Okay, so here also there will be obstruction to the pulmonary outflows in Epstein's anomaly. Also pulmonary severe pulmonary stenosis, pulmonary atresia, and also in Epstein's anomaly the blood from right ventricle, right atrium will not circulate to the pump to the right ventricle, and also there will be obstruction to the pulmonary outflow tract because these tricuspid walls they will collapse into the right ventricle, and they will obstruct the pulmonary outflow tract. Okay, due to this there will be pulmonary outflow tract obstruction, Epstein's anomaly. Transient, so TGA, great transposition of great arteries without significant mixing. So if there is a transposition of great arteries, means the in the place of aorta there will be pulmonary artery. In the place of the pulmonary artery there will be aorta. So here there will be transposition of the great arteries. So if there is aorta in the place of pulmonary artery, from the right ventricle the blood goes to the aorta, and deoxygenated blood goes to aorta, and it will supply to the systemic circulation. So it is of no use. If there is mixing, if there is significant mixing at right VSG or ASG, then it is okay. If there is no significant mixing, then this lesion is dependent on the ductus arteriosus. Ductus arteriosus should be there to help for the mixing of the blood. Next, severe tetralogy of palate, and other examples are obstructive TA, PVC, and tricuspid atresia. So all these lesions, for the mixing of the blood, there should be ductus arteriosus, patent ductus arteriosus of the blood. Otherwise the baby will have severe cyanosis, because the blood is not going to the lungs for oxygenation. Okay, because of the obstruction of the pulmonary outflow, right ventricular outflow, pulmonary arterial outflow. So there should be at least some mixing. For that the ductus arteriosus should be open. So these lesions are ductus arteriosus dependent. When the ductus arteriosus gets closed, these lesions will present. If you leave like that without treatment, the baby can go into shock, hypoxia, acidosis, poor perfusion, shock, and finally baby may die. Next is systemic blood flow obstruction. Systemic blood flow obstruction is a left ventricular outflow tract obstruction. What is the left ventricular outflow tract? It is aorta. So there will be obstruction in the aortic wall or in the aorta. Okay, so when there is obstruction of the systemic tract, mainly they will present with shock, not with cyanosis. If there is obstruction to pulmonary blood flow, they will present with cyanosis. If there is obstruction to the systemic blood flow, because there is low cardiac output, the blood cannot come out from the heart, so there will be low cardiac output, presents with shock like weak pulses, increased, means shock means shock means nothing but the bloods will not circulate to the organs. Blood will not circulate to the organs of the body, all organs of the body. Okay, either kidneys or lungs or liver, intestines, brain, skin, any part of the body, the blood will not circulate, because the heart is the pumping organ, and from the heart, when it pumps, the blood should go out from the aorta, from left ventricular outflow or left ventricular outflow tract. But if there is obstruction to the aorta or left ventricular outflow tract, the blood from the heart, if it pumps also, it will not go out. Then this is called shock. There is no supply of the blood to the different organs of the body. This is known as shock in medical terms. Okay, then it will, if there is no blood supply and if there is no pumping effect and no blood supply, then you will have weak pulses. Pulses will be very feeble or absent, and increased capillary refill time. If you press on the skin near the sternum for 5 seconds and release, usually the blood will rebound and it will refill in 3 seconds. If it is does not leaving, then if it is delay or absent, then it is a sign of a shock. And there may be murmur, cardiac murmur might be there, or low blood pressure, because there is no circulation. Low blood pressure will be there, cold extremities will be there, pale color will be there. Okay, pale, baby will look pale because there is no blood circulation. If there is blood circulation only, then baby looks pink, and baby will be warm. If there is no blood circulation, there will be cold extremities, pale color, low blood pressure, delayed or is absent capillary refill time, and weak pulses will be there. Okay, decreased urine output will be there, because if there is no blood flow to the kidneys, there will be decreased urine output. And example, and baby might presenting heart failure. Okay, heart failure, all these signs are of the heart failure only, heart failure and shock. Okay, examples are severe coarctation of aorta, means the aorta, there will be narrowing of the aorta at some stage of the truncus, at the some stage of the aorta. Okay, there will be severe coarctation of aorta and interrupted aortic arch, and severe aortic stenosis. Okay, severe aortic stenosis or atresia, and hypoplastic left heart syndrome. So in all these lesions, there will be obstruction to the pulmonary systemic blood flow, severe coarctation of aorta, interrupted aortic arch, severe aortic stenosis or atresia, hypoplastic left heart syndrome. In all these conditions, there will be obstruction to the systemic blood flow. So in systemic blood flow, mainly the patient will present with shock after 12 to 48 hours. They will present in so when they present with shock, first differential diagnosis, you should look for sepsis, septic shock. Next, you should look for any bleeding or anything, and if those things are excluded, then you should come to cardiac shock. If there is bleeding, there will be some history of trauma, or during delivery trauma to the head, or if there is any coagulation disorders like platelet count increase, rapidity. So there will be history for bleeding. If there is no history for bleeding, or or no history of trauma, and if there is no septic markers elevated, then if after ruling septic shock or hypovolemic shock, then you should come for cardiogenic shock. So cardiogenic shock is mainly because of these lesions. Okay, so the systemic blood flow obstruction will present as cardiogenic shock, and pulmonary blood flow obstruction is present mainly with cyanosis, and also finally it will also lead to shock, decreased perfusion. So how you will manage these duct dependent lesions? So there should be some mixing. If the pulmonary circulation is obstructed, some blood from the systemic circulation should come into pulmonary circulation and should supply the lungs. If the pulmonary circulation is obstructed, some blood from the systemic circulation should supply lungs. If the systemic circulation is obstructed, some blood from the pulmonary circulation should supply all the systemic organs. So how this mixing will occur? Only there is if there is ductus arteriosus patent only, then this mixing will occur and save the baby. So usually after 12 to 48 hours, usually immediately after birth, in 5 to 10 minutes the ductus arteriosus will functionally close, but the structurally it will close in 1 to 2 days, okay. So when it is structurally closing, these symptoms will appear. So you should make the treatment is, you should make the ductus arteriosus patent, okay. Initially, first all critical cases, look for airway, breathing, circulation, okay. Airway should be patent, breathing should be, so if airway is not patent, you intubate, and if breathing, if it is not taking breathing properly, connect to the ventilator. Circulation, if there is shock, you should, in cardiogenic shock, you should not you should not give more boluses, only 10 ml per kg, that's all. That too very slowly. If poor perfusion and reduced respiratory effort, intubate. I told you, no, airway, for airway and breathing, intubate and ventilate. And if for inotropics, you should not give more boluses, start inotropic support, okay, like dopamine, dobutamine. For cardiogenic shock, you should start dobutamine is the first line of drug. Then next step is so always look for ABC. For airway, intubate and ventilate, and for breathing, ventilate. For circulation, you and normal saline bolus, and also inotropic support, okay. Next step is you should put the this ductus arteriosus patent. For that, the treatment of choice is prostaglandin E1 infusion, okay. Prostaglandin E1 infusion, 0.05 to 0.1 mics per kg per minute. Infusion should be started immediately, and this will help you to maintain the prostaglandins, will help to maintain the patency of the ductus arteriosus, okay. This is a temporary. This will help you temporarily until you reach the tertiary care center. It will help to maintain the ductus arteriosus patency. After reaching the tertiary care center, you should do the definitive correction surgery, okay. Definitive correction of the lesion, this obstructive lesion correction should be done. So this is about the duct dependent lesions, how they will present, when to suspect the duct dependent lesions. If the severity of the obstruction is more, they will present very soon after birth, okay. If there is pulmonary obstruction, there will be cyanosis, which will, and low SpO2, which will not improve even after giving 100% oxygen, or if even after you ventilate also, it will not improve. Then you should differentiate from respiratory causes and also respiratory arterial lung pulmonary arterial hypertension by hyperoxia and hyperventilation test. Then you should suspect this pulmonary blood flow obstruction, okay. Now all these pulmonary stenosis, pulmonary atresia, abstinence anomaly, severe tetralogy of Fallot, okay, all these are the examples for the pulmonary obstruction, tract obstruction. Systemic blood flow tract obstruction will present with shock. I already said the signs and symptoms of the shock, okay, and examples. So main treatment for any critical case, you should look for airway, breathing, circulation. For airway, intubate and ventilate, start with 100% oxygen, start inotropic support, or give boluses. In cardiogenic cases, don't give more bolus, only 10 ml per kg, and start prostaglandin E1 infusion. This is temporary treatment to maintain the patency of the ductus arteriosus until they reach the tertiary care center for definitive surgery. Thanks for watching my video. If you have any doubts, you can put in the comment. If you like my video, press the like button and subscribe to my channel. Thank you very much. If you want any videos, any topics to be explained, please put in the comment. I will try to explain you. Thank you very much.